Good evening. Welcome to Let's Talk About Mental Health and Addictions. I'm Nels Kloster. I'm a psychiatrist who works in Southern Vermont.
And I'm Robert Stack. I'm a licensed alcohol and drug counselor, mental health counselor. Good evening.
Tonight we're having our fourth episode. So fortunately over that time we've at least attracted one or two people watching because we got some questions via email.
You know, it's very strange seeing yourself on TV or computer, you know.
Yeah, I know.
It's very strange.
I cringe every time I watch myself, believe it or not. So the first question, I've been taking lamotrigine 75 milligrams since the fall of 2009. It's done wonders for me around mood swings, a manic episode in the summer of 2009, and seasonal affective disorder. However, even though I review my medications to my primary physician, at least at my yearly meeting, I'm no longer in contact with the psychiatrist who originally prescribed it. So my question is this dosage a one that I can take for a lifetime without the risk of creating collateral physical damage? As far as I know, I have had none so far. Okay. Yeah, no, that's a great question. Not just about Lamictal, but about medications in general, I think. Again, as we've said so many times, having you function well is really what matters with these kinds of treatments.
Mm-hmm.
Whether we're talking about bipolar disorder or other physicians are talking about a pain condition or anxiety, really the medication should be used to help you function better. And what we know is that most of what we call the psychotropics or psychiatric medications aren't known to cause any problems like cancer, for example. And if you're not feeling any kind of effects now, such as weight gain or any of your blood work that's been done has been fine, then what we think is that the longer you take a medication, the less likely you are to have a relapse. Mm-hmm. Back in the decade or so ago, we used to think that take a medication for a shorter period as you might need to take it, and once you're feeling better, then start to taper off of it. Now what we've realized from more study is that the longer you take a medication, that the healthier you seem to be. And of course, there's a difference of opinion about that as well. You'll find some people still say to be on it for a shorter period of time as possible. But I would say that if you're doing well and you're not having any kind of difficult side effects from the medication, why rock the boat? Things are going well. And at this dose, there's plenty of room to go higher if there should be a deterioration of your mood, or even to decrease it and see how you do on a lower dose, because I think many people like the idea of being on an optimum dose, not the maximum, not the minimum, just right dose, like the whole Goldilocks business with the porridge.
Yeah, I just want to mention with the seasonal affective disorder, a friend of mine had that and found a lot of comfort using a certain type of light bulb. And they did that every day, and that really seemed to help them a lot with that. So I don't know if that's something that is prescribed or not, but
absolutely, you can get these lamps. They're called full spectrum lamps. They mimic the sunlight. The prices come down. I think you can get a good lamp for maybe about $75 or $100. And the idea is that around seasonal affective disorder, we have a sleep shift, which goes from regular time to later and later in the day. Right. And what this lamp does by mimicking the sunlight and by sitting in front of it full force for a half hour to an hour a day, does wonders on mood. Very well proven and cheap, and definitely a safe treatment for seasonal affective disorder.
Now, would you recommend that they get a new psychiatrist? Because I guess there's a part of me that feels like, especially that part of that was about the manic episodes. I mean, that jumps out to me. I mean, I'm sort of, I don't know. I was, with all due respect to the general practitioner, I think I would.
Well, and that's tough because there are so few psychiatrists. If you ever try to get an appointment with one, good luck. There's a long waiting list. And I think that the way a lot of psychiatrists are working these days, and maybe the way the future is going, is that this is a specialty, a consultative specialty, and that they might psychiatrists start working more as consultants to primary care. And so just like if this was surgical issue that was no longer causing any problems, you wouldn't have regular contact with your surgeon in the aftermath of the surgery if all was going well. Okay. So I think that we could look at it in this fashion as well.
All right. I just think that even if they had to wait a long time to get in to see a psychiatrist, I guess I would still follow up and see one, and just do a little med review and talk a little bit about it. But anyway.
That's possible. You might find somebody who would do that for you.
Put a plug in for psychiatry. There you go.
Absolutely.
All right.
So you have another question. I heard you mention a few times cognitive behavioral therapy. Can you give me a general overview of it? of course, with some personal anecdotes as well for which diagnosis, and as well as for which diagnoses it is most effective.
Well, I don't know about these personal anecdotes.
Probably stories about other people.
Other people, no. But I think that, you know, I've mentioned it a couple of times because talk therapy, I really like it. You know, I don't know if I could do it justice. I mean, it needs a show of its own, really, quite frankly. But the big deal for me is this whole core belief system that we all walk around with. And two that I've gone back and read, you know, two that you really worry about is when people have these core beliefs of A, that they're not good enough, or B, they're unlovable. Right. And then all life events get sort of filtered through that prism, if you will. I mean, I used to tell people it's like going into a funhouse carnival and you have those funhouse mirrors that make you fat and skinny.
Distorted view.
They're distorted views. And they're funny because you know they are, but I think sometimes we have cognitive distortions and we see the world a certain way, and it's really hard to come to understand that the way we see the world is not the way it is. Yeah. If you've ever known somebody who was overly suspicious or paranoid or saw the worst in people, I mean, you know, other people might say, well, geez, how do you see the world? Yeah. So anyway, so I think that you know, we're not getting into personal stories, but I mean, one of the things that's helped me immensely is to get to know some of my core beliefs. Mm-hmm. They're always there, and I laugh at myself. Like I go, oh, there you go again. You know, I go right there. You know, and they say, I've heard somewhere, at least in the beginning of therapy, you're not responsible for your first thought. You're responsible for your second one. Because my reactions tend to be a certain way. And then I have to sort of go, okay, let's not go there. Let's take a different point of view. Yeah. And really, if you just one more minute. So if you have the core beliefs and you have an activating event, if you will, something occurs, you interpret it, your subconscious interprets it, and from that comes your behavior and your emotions and your physical response. Like we can't tell our body to produce adrenaline, but our brain can decide that we're at risk or at danger and you need to go on alert and stuff like that. So I guess in some ways it's like almost coming up with an alternative interpretation of different life events that things occur and changing the way I react to it. And I think that's been really successful for me. I think now I have different sets of core beliefs. I have my old core beliefs and then I have new ones that I've sort of tried to develop to make my life go a little easier. Yeah. But I don't know if that really worked for that. But that's a huge topic. And
tremendous. It's the emotions really to sort of click this off for you. I know that they become overwhelming and we don't think anymore. We just sort of react and we feel. And a big piece of that is if you can recognize, sort of stop yourself and then think, what am I thinking about right now? And I know that, you know, personally, when I get into kind of a snit or something, if I stop myself, why am I thinking this way, feeling this way? Why am I so pissed off or why am I so anxious? And then work it back and then sort of look at the evidence for or against those distorted thoughts that I'm having. And then that helps to decrease the anxiety, helps to decrease the sadness or the anger, you know, whatever the emotion might be at that time. And that's the real beauty of it, is that it sort of gives you some power then to reevaluate how you're thinking and feeling. And it's even, like you're saying, being a fan of talk therapies. You know, a lot of folks would tell you that cognitive behavioral therapy can be more effective than medications. And more effective when it practices without medications, at least initially.
Yeah, and it's sort of like when I was working with addicts and talking to them every day, I mean, a lot of them felt they were at the mercy of other people, life events. And that seemed outside of their control. And I think one of the nice things about cognitive behavioral is not, you stop trying to figure out how to control other people in order to control your emotions. In other words, other people make me so angry. No, not necessarily. It's your reaction to other people that make you angry. So if a guy cuts me off on the highway and I decide it's disrespect and I want to blow the horn, give him the finger, you know, and I can go there, and that's a pretty unhappy kind of existence. Or I can just say, gee, there might be an emergency at home and I wish him well. Now that seems Pollyannish, but on the other hand, it's a lot easier for me.
Maybe just, gee, that guy's a really bad driver.
He's a bad driver, and plus I've done it myself. I mean, you know, it isn't like I've never cut nobody off.
Yeah.
You know, I've done it. And,
Yeah.
you know, so anyway, it's that idea that you're not at the control of other people, of other events and other actions. It's really about your reaction to them. And that's what I sort of like the best about it.
It's empowering. I often use that expression that if you give a person a fish, they eat for a day. If you teach a person how to fish, they eat for a lifetime. And I think cognitive behavioral therapy, as far as therapy goes, is really along the lines of teaching people how to fish.
Yeah. And it has to be something that you want to change. That's the other thing I like about it. You have to say, I don't want to be so angry all the time. I don't want to yell all the time. Or I don't want to do this. And once you're motivated to change, then we can change it. Somebody else telling you to stop being so angry, that doesn't work.
I think
That's not going to happen.
We all know how much luck we've had trying to change other people. I might as well just focus on myself and make those changes there. And I think the other piece of the question was, what's it good for? And I think the depression and the anxiety disorders are primarily what it was originally intended to treat. But we also find ways to use it for the whole spectrum, whether it's bipolar disorder or schizophrenia as well. There's a place for looking at the sort of reality testing and looking at your thoughts.
And at least have a little idea that maybe the way I see things is not the way it is. I mean, just to have a suspicion. Like, I'm colorblind, so I know that my perception of colors is not what they are, and it's different than other people, which makes shopping sort of an adventure.
Yeah.
But, you know, I mean, the idea is that I've come to know it. You know what I mean? Like, I understand this is the way I see it. I see things, or I don't see things that other people see. And it's, you know, it's not life-threatening.
So here I go again.
Yeah, but cognitive therapy can deal with those things that are almost life-threatening, or they destroy relationships. And people even look at you sometimes and say, "What were you thinking?" You know what I mean? Like, they're really surprised. They're like, "What was that about? Like, what was that about?"
It wasn't a big deal.
Like, almost any time you overreact, you can almost look at your core beliefs and say, you know, there's something funny going on here, because I see this really different. This really gets me upset. And it has something else. All right, we should move on.
Yeah, let's move on.
All right,
So here's a question. I understand that Medicaid pays for Suboxone and methadone for opiate-addicted people. Can you explain why our tax dollars should pay for these medications? Now that's putting it really bluntly.
Yeah.
Right? I've heard this kind of criticism in more subtle terms, like the idea of why would you treat an addict with a drug for a drug?
Yeah.
Right? Methadone's an opioid, Suboxone's an opioid. Why should I do that? So I mean, there are a number of directions we could possibly take those.
Well, there's two ways. I mean, if you don't mind.
Oh,
I mean,
please.
one is the benefit for the person.
Right.
I mean, obviously, and the other one is the benefit for society.
Gotcha.
So, you know, if you have somebody who's an opiate addict and they are compelled to take their drug, and we can talk about addiction in another place, but the idea being is that they're dope sick and they want their drug. And people do things that are just horrible. They break the law, they do things they wouldn't normally do. They get involved in selling to supply themselves, they get new users. They run the risk of jail, imprisonment, infections, hepatitis C, HIV. So there's so many negatives associated with the drug use that just from a point of view of what's benefit for all of us as a society is to help an addict with their opiate addiction, with medication. And now I understand, like you said, some people say it's opiate substitution, and that usually means they don't support it.
Exactly.
But if you hear somebody say it's a medication that we use to treat opiate addiction, then you understand that this is somebody who sees this as a psychiatric disorder and we need to treat. And obviously for the individual, the lifestyle associated with illegal drug use is just heartbreaking. It's heartbreaking for the family. It's terrible for, these are people who love their children just like we love our children. Right. These are people who are, for whatever reason, whether it was through pain or whether it was trauma or whether it was childhood environmental issues, no one wakes up and says, I think I want to be an opiate addict. I think I want to be a junkie. I think I want to break the law. I appreciate if somebody wants to say, I don't want to pay that money.
I'm the medical director at the local methadone clinic.
Right.
So a little disclosure there. And people will ask, well, why do you do that? How can you do that? And maybe it's not humorous, but I say, one of the things I'm doing by doing this work is I'm protecting my house, my car, my kids from being robbed. I'm protecting your home as well from being broken into. So really, it's the opiate-dependent patients, the opiate addicts who are not in treatment, that are ones that we should be concerned about. And if you look at it on just a economic basis, folks have analyzed, how much payback there is for each dollar spent, for example, on trying to eradicate crops in Colombia or Mexico. How much we get off of sort of border control and such. And those sort of war on drugs kind of activities, they pay back maybe anywhere from 30 cents to 75 cents on the dollar. So we wouldn't put our money in that bank. If I put in $1 and I got back 30 to 75 cents, I'm not going to make that investment anymore. If you look at the investment in treatment, whether it's specifically for methadone or for addiction treatment in general, the payback ranges from $4 to $7.50 per dollar spent for addiction treatment.
There you go.
And that encompasses decreased medical costs, decreased legal system corrections, judicial costs, and then it takes into account too sort of the productivity that comes about from people no longer engaged in illegal activity, no longer engaged in sort of unsociable sort of activities, who then find themselves free to the physical burden of the withdrawal from the drug, and are able to go out and get a job. And so that's really the joy when you see that start to happen. And people get employed, they come in wearing a uniform from work, they're no longer on Medicaid. And that's a reason why this is money well spent.
Oh yeah, and if you don't mind, I just mentioned, because it's one that we used to treat. Sometimes women who get pregnant who are opiate addicts, and the great tragedy is a lot of the times when women get pregnant, to protect the fetus, they'll stop doing drugs, and as you know, that would sometimes cause a miscarriage because of the withdrawal factor. So now we can reach out to women who are opiate addicts if they're pregnant, try to provide special services, get them on the right medication. When the baby is born, detox the child. The baby seems to do okay with a good, safe detox. If you need to, that's right. And really, Dr. Kane that I work with, he used to talk about our medications as a bridge. And when I used to hear, before we approved Suboxone, the feds used to say, look, we just want to get them in the system. We want to get them into the medical treatment system. And we'll use this to get them in, we'll treat them, and hopefully the idea is that, especially for Suboxone, I think, is that it might be actually a transitional medication. How do we go from a daily opiate habit, oxy IV drug use, get you into the system, get you taking the meds, steady your life, get a job, get a home. So that's how I see it, and I appreciate somebody saying, well, it's my tax dollars, but I think it's money well spent.
Absolutely.
I'm sorry.
I love a blunt question like that.
Yeah.
Right to the point.
Yeah, and I think it's valid. You can ask that. I mean, why do they go to the head of the line? Or
we should ask that about every medical treatment.
That's right.
Why am I spending my tax dollars on that?
And I think it's money well spent, but I appreciate.
You could ask that about hip surgery, open heart surgery. Absolutely.
God, they want this one.
So another question here. I'm a nicotine addict and feel hopeless about quitting again. I stopped for 12 years and picked it up again 2 years ago. Now I can't seem to find the motivation to stop again. Can you help? Oh, sure. It sounds like the crux of this question is, where's the motivation going to come from?
Yeah. Well, it's kind of sad, and I know in the field of alcoholism, sometimes when people are absent for long periods of time, when they pick up again, they have a real hard time getting back their abstinence. Yeah. There seems to be something about that. I mean, the fact they're picking up the phone or emailing this, I think they're motivated to stop.
Something's going on there. They're thinking about it.
They're thinking about it, yeah, and they know that they can do it. It is doable. And I think one of the things I saw recently about motivation is to try to build in rewards that are more immediate, rather than saying to somebody, if you stop smoking now, you'll live to be in your 80s. I mean,
well, like they did with kids. They didn't talk about emphysema and ugly lungs. You smell funny, your breath is bad, you never get a date.
There you
got to find something right now that really matters and gives you a positive reason to do this.
And move toward, pick a date to stop, take a look at using gum. Patches have been really effective for some folks.
A medication called Chantix, which is out there as well. It works at the nicotine receptors.
Yeah, and don't get discouraged. I mean, keep trying and cut back on how much you're smoking. Keep track of it. Some people used to keep a journal, pick a date to quit.
Developing awareness of what's going on rather than this automatic.
Contact the Red Cross, talk to your doctor. So, it could be, by the way, it could be you just don't want to stop smoking. I mean, and that,
Admit it.
It's like, you enjoy it, you like the nicotine. It sort of led to the settlement of the Jamestown in Virginia was the discovery of tobacco. Every other venture failed down there, but they found this addictive drug that people liked, and it was the beginning of the colonization of Virginia was tobacco. And,
so we owe tobacco plant, huh?
Well, it played a role. Anyway. So
now this next question is about something else that people around here smoke, meaning Vermont, Brattleboro. I'm the mother of a 16-year-old boy, and I'm a user of medical marijuana for dealing with the nausea from my chemotherapy. What kind of message do you think this gives my son? Do you think marijuana is addictive? Boy, I don't think with the rest of the time. We could go on and on about this, you and I, because we have in the past.
Well, we have
conversations that we've had.
We don't want to get into the controversy of arguing with the people about the decriminalization, though. I'm not a big fan of it. We want to be helpful to people with questions like this. I think you can become dependent on marijuana. Smoke it every day. People like getting high. They like being stoned. I understand that. I don't know. I've never had chemo.
Right.
If it helps with your nausea, I don't want to argue with it. The state has medical marijuana, and so I don't think we can roll that back. But the other thing I would be more worried about your 16-year-old son who is worried about his mother who has cancer. And I guess I'm not that. I'm not sure.
So you're kind of
not sure how to answer.
So the thing that jumped out for you about this question was not the marijuana piece of it, but was rather the relationship with the mother and the son. How worried he must be that the mother's having chemotherapy. Because
it might, some of the times when I've interviewed clients who end up opiate addicts, now I know all the pots are going to go crazy, but a lot of them started off smoking pot. Okay,
it's like gateway.
But anyway, but the ones that got high with their parents were often tragic. I mean, you know what I mean? I think that's something I would be really careful about it and understand that it's medicine. And you've said this to me, and I don't mean to take your line, but is there another medicine you can take for nausea?
Right.
And, is there something else that you could take if you really felt that it was a bad example for your 16-year-old son?
Yeah.
If he ended up smoking pot to deal with his fear and his grief about your cancer, I think that would be worrisome.
Yeah, and if it's in the house, it's more available. And I think that's one of the things that we've always talked about, being concerned about, the decriminalization or depenalization or legalization of it, is that availability means more people are going to smoke it and more people are going to try it. The earlier you try it, the more risk there is for addiction. I think too, I think I have to agree with you. I mean, one of the whole idea of this medical marijuana piece, I don't think we're at a point now where marijuana should really be considered medical.
Yeah.
Now, of course, opioids are derived from plants, from the opium poppy. We've been able to refine those so that we know exactly how much people are getting. The delivery system is oral. You swallow a pill, so not much harm in that. One of the big issues you're going to find from all the professional bodies who talk about medical marijuana is the delivery system. Smoking is not a healthy way to take any medication. You can't control the dose. It has carcinogenic products in it. It's damaging to the lungs and the tissues. So for that reason alone, I have to argue that we're not at a point now where we have studied marijuana, or we have broken down the constituents to the point where we're able to offer sort of a broad range of medications that could treat the unbelievably broad range of ailments that people attribute to being helped by marijuana.
I'd also say that a 16-year-old boy has already made a decision about pot. And there are kids in our high school who do not smoke pot. And more credit to them, because every day they have an opportunity to ask somebody for pot.
Right.
It's there. You've made the kids are making that decision at 12, 13, 14. Are you going to smoke pot or you're not going to smoke pot? Is this part of your life or this is not part of your life? And it's sort of interesting, I think, on some level, because you'd have to be careful about this. But if marijuana was just seen as a cancer medication, it wouldn't be a problem.
Okay.
But it has a street rep. You know, this idea of being stoned and, you know, getting the munchies and, you know, all the culture that goes with it. But, you know, maybe the son, you know, he's already decided.
So maybe the question is what should you be looking for in your 16-year-old son who you're afraid is going to start smoking marijuana? Stealing, borrowing your medical marijuana, and then probably what he's engaged in socially. Is he engaged in school activities? Is he involved with clubs or sports or any kind of healthy, positive activities? That seems to be a very strong indicator of whether or not adolescents, teens are going to get involved with drugs.
You know, when I was on the school board of Brattleboro High School and Guilford, and they used to talk about doing urine screens for sports, and other schools do it and stuff. But I always thought we ought to do urine screens for kids who don't do it, and reward the kids who don't. No, the kids who don't use. Yeah. I mean, really. I mean, quite frankly, I always thought that, you know, the children, you know, they make a decision instead of looking for the kids who are using. Congratulate the kids who aren't using.
Right.
Give them credit. Give them. I mean, I mean that. You know, we know that if we can put off the age of use, we can decrease dependency. So I guess you know, that's such a big question. I think, you know, you can't just say, well, if I smoke pot, my son will smoke pot. If I don't smoke pot, my son won't smoke pot. You know, I don't think it's that clear. And I appreciate the question. I'm sorry to hear that you're struggling with the chemotherapy. I hope you get well. But I think your son has probably already made some decisions and choices around marijuana and around drugs in general.
Yeah, but still, 16 is no time to abdicate on your authority of being a parent.
That's right.
That's right. I think we've said that in previous shows too, that it's very important you recognize that.
And I would not let it be available. I wouldn't do it, God forbid, with him. It is such a wrong message. It is such a bad message.
A number of colleagues of the professionals I've talked to, not really looking at any kind of research about the issue, but there's definitely the sense that when parents and children use drugs together, that is not good.
Yeah.
That's not good.
And you know, teenagers sometimes will present themselves as they have all the answers. But really what they're trying to figure out is, what is my moral code? We talked about core beliefs earlier.
Right.
What are my core beliefs? Yeah. What are the things I believe in?
Who am I and what do I stand for?
Yeah. So this is really tough stuff. I don't know about parenting. One more very quickly?
It looks like we're running out of,
all right.
running out of time.
Okay. Well, I enjoyed talking about this. I mean, I hope people who are listening, I hope they enjoy it.
And I think you're taking feedback as well. I think last time, we've heard a couple of times, if you guys just answer 3 questions a show, that drags on a little bit. So I would love to hear back. I hope that worked a little bit better. This time we tried to kind of go a little more quickly, get more across more topics. Of course, now we're getting more questions too, so maybe that helps us as well.